My name is Russell Samson, and I've been asked by the SVS to describe our experience with setting up a surgeon-owned outpatient endovascular suite. Our group believes that these centers will become more mainstream and will prove beneficial for patients, insurance companies, and the surgeons who own the suites. We set up our suite in 2007, and since then we've performed over 4,000 procedures. And these have included diagnostic arteriograms, peripheral angioplasties, and stents of aortoinguinal arteries, as well as diagnosis and interventions for patients on dialysis. During this time, we've had to send only 5 patients to the hospital for complications, none of which led to any long-term morbidity or mortality. Before establishing our center, we researched literature to evaluate the safety of outpatient procedures that had been performed in cardiac cath labs, as well as hospital-based outpatient facilities. We also had a long experience with safely doing same-day discharge of our hospital interventions. Once assured that the procedures could be safely performed, we partnered with an interventional radiologist and built an endovascular suite in the first floor of our new office building. The facility has a 3-bed pre-op area and a 3-bed post-procedure area. We have hired 3 nurses, 1 full-time and 2 part-time radiology technicians. We have a fixed Philips overhead angiography unit and stock all the necessary balloons, wires, stents, and related disposable equipment. We contract with a local anesthesia group who provide us with either an anesthesiologist or nurse anesthetist for all our procedures, and they bill separately for their part of the procedure. We have negotiated with industry to provide us with our disposables at very competitive prices. We have also been compulsive about reducing the cost of the procedures without compromising patient care. The center has proven to be very financially rewarding for our practice, as well as being extremely convenient. Insurance carriers are happy to deal with us since we have kept our prices well below those of the hospital. The patients are delighted to be treated in our unit since parking is freely available, and they do not have to deal with the complex admission process that is required in the hospital. Our nurses and staff are our employees and therefore provide the personal attention that overcomes the patient's natural anxiety and fears. Currently, we perform 3 to 4 procedures every morning, allowing for a 3 to 4 hour post-procedure stay in our recovery area. Having the facility located in the same building as our office increases our efficiency, allowing us to see patients or do office work during turnover. Now, we acknowledge that our format may not work for all practices, but we believe that with careful planning, most practices of more than 3 surgeons should be able to profitably and safely set up their own suite. Now, this may take partnering with other surgeons, cardiologists, or interventional radiologists. The suite can be built for far less if a portable C-arm is used, but we believe that the quality of a fixed overhead unit, as well as the efficiency that such an overhead unit offers, makes the expense worthwhile. I've published a more extensive outline on what it takes to set up one of these centers in the Journal of Vascular Surgery. I'm hopeful that more surgeons will follow our lead in establishing their own suites. I'm also hopeful that surgeons will be careful not to overextend what they do in these facilities and not to abuse them for profit.
This briefing is made possible by a grant from Cook Medical. To learn more about vascular health, visit vascularweb.org.